Picture a small, timber-framed chamber in a Norman infirmary, sometime around the year 1180. The floor is strewn with dried rushes. A single tallow candle burns low. On a plain wooden bench sits a farmer of about 40, sleeves rolled to the shoulder, his left arm resting on a folded linen cloth. Standing beside him is a monk in a black woolen habit, holding a shallow earthenware bowl. From that bowl, the monk lifts a dark, glistening creature the length of a finger. He presses it, gently, to the pale skin above the inside of the patient's elbow. The farmer flinches, more from anticipation than pain. And within seconds the creature has fastened itself in place, 3 tiny jaws locking down in a bite so precise it leaves behind a mark shaped like a 3-pointed star. Nobody in that room finds any of this strange. To them this is not superstition, and it is not desperate improvisation. This is state-of-the-art medical practice, endorsed by the ancient physicians of Rome, refined by the scholars of Baghdad, taught in the new universities of Bologna and Salerno, and considered by every reputable authority on earth to be one of the most reliable tools a healer possessed. To understand why medieval doctors reached, again and again, for a swamp-dwelling parasite as a first-line treatment for everything from fevers to melancholy to the plague itself, we have to go back to a set of ideas so deeply woven into the medieval mind that the word for a doctor was, quite literally, the word for the creature crawling up that farmer's arm. The English word leech, when applied to the animal, is not the older meaning. The older meaning is the physician. In the surviving Old English vocabulary studied by philologists at the University of Cambridge, the word lacy referred first to a healer, a person of learning who tended the sick. The Book of Medicine compiled in 10th century Winchester, now catalogued at the British Library as Royal 12 DXVII, and known to scholars as Bald's Leech Book, is not a book of worms. It is a book of prescriptions written by and for physicians. The word leech only migrated to the aquatic parasite over centuries of association, because the practitioner and the creature were understood to do the same work. Both drew out sickness, both removed what should not be there, both restored in the medieval imagination the delicate equilibrium of a body. That equilibrium had a name. It was called humoral balance, and for roughly 1500 years, from the writings of Hippocrates in the 4th century before the Common Era to the reforms of Louis Pasteur in the late 19th, it was the dominant theory of how a human being got sick and how a human being got well. The theory went like this. Every body contained 4 fluids, and these fluids were the humors. There was blood, produced by the liver and associated with the season of spring, the element of air, the qualities of warmth and moisture, and the temperament called sanguine. There was phlegm, associated with winter, water, cold, and the calm phlegmatic disposition. There was yellow bile, tied to summer, fire, heat, and the quick-tempered choleric humor. And there was black bile, the humor of autumn, earth, dryness, and the brooding melancholic mind. Health was the harmony of these 4. Illness was when one of them overflowed its proper measure and drowned out the others. A patient burning with fever, red-faced and irritable, was suffering from an excess of blood. A patient racked with chills and heavy discharge was drowning in phlegm. A patient consumed by grief that would not lift was buried under an accumulation of black bile. The historian Nancy Sirazi, whose foundational study Medieval and Early Renaissance Medicine, published by the University of Chicago Press in 1990, remains the definitive English-language survey of the field, describes this framework as more than a theory of disease. It was a total map of the human being, a cosmology in miniature, in which every symptom pointed to a specific imbalance that a competent physician could name and, in principle, correct. If illness was an overflow, then the treatment followed logically. You drained the overflow. You could drain it through the gut with purgatives. You could drain it through the skin with sweats and blister-raising plasters. You could drain it through the nose with sneezing powders. Or you could drain it, most directly of all, by opening a vein. Bloodletting was not one option among many. It was the master procedure. It was to medieval medicine what the antibiotic prescription is to a 21st century family practice. It was the default response, and its logic was so elegant, so internally consistent within its own framework, that arguing against it required attacking the entire edifice of learned medicine at once. And this is where the leech came in. because opening a vein with a lancet or a fleam was a violent business. The patient's arm had to be bound with a tourniquet, the vessel raised, the blade struck sharply through the skin, the bleeding then measured carefully into a shallow basin and stopped, ideally, before the patient fainted or died. It required an experienced hand. It carried real risk. The leech, by contrast, did the work for you. Hirudo medicinalis, the European medicinal leech, is a segmented worm that has evolved, over hundreds of millions of years, into an almost perfect surgical instrument. Molecular studies published in BMC Evolutionary Biology by researchers at the American Museum of Natural History in 2009 traced the medicinal leech lineage back through a deep divergence in the family Hirudinidae, indicating that the traits which made the animal so useful to medicine are the product of enormous evolutionary time. The mouth carries 3 sharp jaws arranged in a Y shape, each lined with roughly 100 fine teeth. When the leech bites, it leaves the small 3-pointed wound that later observers would compare to a Mercedes-Benz emblem. And into that wound flows a saliva that is, from the standpoint of anyone who needed a controlled and painless bloodletting in the year 1180, a small chemical miracle. The saliva contains an anesthetic, so the bite is barely felt. It contains a vasodilator, which widens the local vessels and encourages steady flow. And it contains a compound called hirudin, first identified and named by the German physiologist Carl Jacobi in the 1880s. That is one of the most potent natural anticoagulants known to biology. Hirudin binds directly to thrombin and shuts down the clotting cascade at its source. The result is that a single leech, feeding to satiety, will draw about 5 to 10 milliliters of blood from the patient, and the wound it leaves will continue oozing gently for hours after the animal drops off. The medieval physician did not know any of this chemistry. He did not need to. He only needed to know that the leech, applied to a chosen spot on a patient's body, would draw out a measured quantity of what he believed was surplus humor, without a blade, without a struggle, and with almost no pain. From a clinical standpoint, given the tools of the age, this was extraordinary. But choosing where to apply the leech and when was not left to intuition. That decision was governed by a system so intricate that a French royal ordinance issued by Louis XI in 1465 declared that every physician, surgeon, and barber in the kingdom had to own a current almanac in order to legally perform phlebotomy. Similar decrees followed in England and the Low Countries in the decades after. What was in these almanacs was, to a modern reader, one of the strangest things about medieval medicine. They were astrological calendars. Because, in the framework that medieval physicians had inherited from Claudius Ptolemy, whose 2nd-century treatise, the Tetrabiblos, codified the correspondences between planets, signs, and the human body, every organ of every patient was under the influence of a specific zodiacal sign. The head belonged to Aries, the throat and neck to Taurus, the arms and shoulders to Gemini, the chest to Cancer, the heart to Leo, the stomach to Virgo, the kidneys to Libra, the genitals to Scorpio, the thighs to Sagittarius, the knees to Capricorn, the shins to Aquarius, and the feet to Pisces. This mapping was called the Zodiac Man, and diagrams of him, a bearded figure surrounded by the 12 signs each pointing to their assigned body part, survive by the hundreds in medical manuscripts across Europe. The most famous, illuminated in gold and lapis in the early 15th century Très riche art du Duc de Berry, now held at the Musée Condé in Chantilly, shows Zodiac Man standing serene and inscrutable in the center of a heraldic frame. The physician's job, then, was not simply to look at a patient and decide to bleed him. It was to consult the almanac, determine which sign the moon currently occupied, determine which body part that sign governed, and only then decide whether the moment was auspicious for opening a vein at that location. If the moon was in Aries, the physician was warned against cutting near the head, because the sign of the ram was believed to be actively drawing the humors upward at that hour, and any incision would bleed more than intended. If the moon was in Pisces, the feet were off limits. Physicians also had to weigh the patient's age against the phase of the moon, the season of the year, and even the time of day. A comprehensive study of surviving English almanacs, published by Dr. Hilary Carey of the University of Newcastle in the journal Social History of Medicine in 2004, documented the sheer density of these instructions. A single almanac might contain a bloodletting chart, a urine color chart for diagnosis, a zodiac man, a set of prognostication tables, and a list of the so-called dies Aegyptiaci, or Egyptian days, which were considered so unlucky that no medical procedure of any kind should be attempted. Around 1457, a printer in Mainz named Johannes Gutenberg published the first known printed almanac, predating his famous Bible by roughly a year. In the German-speaking lands, the printed bloodletting chart, known as the Adlerless calendar, became so ubiquitous that physicians and barber surgeons displayed them in their shop windows as a signal of professional competence. The chart itself, hanging beside the striped pole of the barber, was proof to any passerby that inside worked a man who knew where to cut and when. And this is where the medieval physician's practice reveals itself as something more nuanced than the caricature of superstitious quackery that later ages projected onto it. Because within the humoral framework, the choices were internally consistent. A physician facing a patient with a pounding, throbbing headache and a red-flushed face would diagnose an excess of blood pressing on the vessels of the head. He would consult his almanac. If the moon was in a favorable sign, he would bleed the patient from the cephalic vein at the crook of the elbow, on the same side as the pain. The theory held that blood drawn from that vein would relieve the pressure at its source. Modern physiology would say that the intervention did nothing useful, and probably weakened the patient. But the internal logic was not stupid. It was a coherent system operating on false premises. The historian Faith Wallace, in her sourcebook Medieval Medicine, published by University of Toronto Press in 2010, argues that this coherence is exactly what made the framework so durable. Any patient who recovered after bloodletting confirmed the treatment. Any patient who died after bloodletting had, by definition, been too far gone. The theory was unfalsifiable, and it was also, for those who worked within it, deeply satisfying. Now, within this landscape of trained physicians and their astrological calendars, the leech occupied a particular niche. Opening a vein with a phleem or a lancet was a procedure reserved for the more educated end of the profession, or for the barber-surgeon guilds, who by the 13th century were formally licensed in cities like Paris, London, and Venice. But the leech could be applied by almost anyone. It required no blade. It required no accurate anatomical knowledge of where the deep vessels ran. It could be used on children, on the elderly, on patients too weak to survive a proper venesection. And, crucially, it could be applied to places on the body where a lancet simply could not go. A leech could be placed inside the mouth to treat what physicians called quinsy, the swelling of the tonsils. It could be applied inside the nostrils, in the ears, on the eyelids, on the gums, on hemorrhoids, on the vulva, on the anus. There was virtually no soft tissue in the human body that the leech could not reach. And because each leech drew only a small measured quantity of blood, the treatment could be titrated, patient by patient, in a way that opening a vein could not. To understand why the leech became so attractive as an alternative to the lancet, it helps to consider what the other options were. The two main competitors to bloodletting in the medieval physician's toolkit were cautery and cupping, and both had significant drawbacks. Cautery was the application of a red-hot iron to a specific point on the body, in the belief that heat drew out corrupt humors and sealed off the source of disease. The technique had its defenders, particularly in the surgical tradition passed down from the 11th century Persian physician Ibn Sina, known in Latin Europe as Avicenna, whose canon of medicine included detailed cautery diagrams that were still being copied in the 15th century. But cautery was excruciating. It left permanent scars, and it required a level of nerve, from both patient and practitioner, that many people did not possess. Cupping was gentler, involving a heated glass or horn cup pressed against skin that had been lightly scarified with a small blade. As the air inside the cup cooled, it created a partial vacuum, drawing blood into the raised wheel beneath. It was safer than cautery and less invasive than venesection, but it produced only small amounts of blood and left circular bruises that could take weeks to fade. Compared to either of these alternatives, the leech was quiet, precise, painless, and produced a controlled, measurable draw of blood, exactly where the physician wanted it. In a medical culture that valued gentleness in its treatments almost as much as effectiveness, The leech offered something the other tools did not. It offered the appearance of medicine without the appearance of violence. The specific applications for which physicians most often reached for a leech reveal the practical logic of the practice. For conditions of the head and face, where a lancet risked accidentally severing a facial artery or damaging a nerve, leeches were preferred. A medieval physician treating a patient for chronic migraines might apply 2 or 3 leeches to the temples, or behind the ears, on the reasoning that the excess blood pressing on the vessels of the skull could be drawn off gently at those locations. For inflammation of the eye, called by physicians the ophthalmia, leeches could be placed on the lower eyelid where the delicate tissue would not tolerate a blade. For quinsy, the acute swelling of the tonsils that could suffocate a patient in serious cases, a leech applied directly to the inflamed tissue inside the throat was one of the few interventions that did not risk immediate hemorrhage. Hemorrhoids were treated with leeches placed at the anus, a practice recommended by the Byzantine physician Aetius of Amida as early as the 6th century, and still being prescribed by London physicians in the reign of Queen Victoria. And for a range of complaints in women that the medieval framework attributed to disorders of the womb, leeches applied to the inner thighs or the vulva were considered a specialty treatment, delicate enough to be entrusted only to experienced midwives or the most senior female practitioners. The evidence that leeches were used extensively in the earlier medieval period is thinner than we might expect. Christine Voth, in her article for History Today in October 2017 examining the manuscript now catalogued as British Library Royal 12 DXVII, notes that Bald's Leech Book, despite the modern connotation of its name, does not actually recommend leeching in the majority of its remedies. Pierce A. Grace of the University of Limerick, in his 2021 paper on therapeutic bloodletting in medieval Ireland, published in the journal Irish Medical History, calculated that of roughly 300 remedies preserved in the Old English medical corpus, fewer than 50 specifically call for venesection of any kind. Anglo-Saxon medicine leaned heavily on plant-based simples and compounds, and the humoral theory, though known, did not yet dominate practice the way it would after the Norman conquest brought closer contact with continental scholarship. The great expansion of bloodletting, and of leech therapy alongside it, came with the translation movement of the 12th century, when Arabic medical texts, themselves preserving and extending the works of Galen and Hippocrates, began flooding into Europe through the translation schools of Toledo and Palermo. And it was in the great Benedictine monasteries that this expanded practice found its most systematic institutional home. A 9th century architectural plan of a Benedictine monastery, drawn up around the year 820 and preserved in the Abbey Library of St. Gallen in Switzerland, shows something that historians of medicine find quietly astonishing. Adjacent to the infirmary, the plan reserves a dedicated bloodletting facility. It contains beds. It contains a privy for the patients. It contains 4 chimneys, so that the monks recovering from the procedure could be kept warm and comfortable. The plan is idealized, and no monastery ever built it exactly as drawn, but it captures the point. Bloodletting was not a rare or emergency intervention in monastic life. It was scheduled, it was routine, it was part of the rhythm of the year. The rule of St. Benedict, followed across Europe from the 6th century onward, did not prescribe bleeding directly, but the customs that grew up around it made phlebotomy, called in Latin the minutio, a regular practice for the brethren. Monks were bled several times a year, whether they felt ill or not, on the reasoning that periodic bleeding kept the humors in balance and prevented disease before it started. The great physician of Salerno, Constantine the African, working in the 11th century, transmitted from Arabic sources a full calendar of when bleeding was most appropriate, and this calendar was copied and adapted across the monastic network for the next 400 years. Bald's Leech Book itself, though sparing in its prescriptions, insisted that the optimum window for prophylactic bloodletting was early in Lent, specifically the month of April. The Anglo-Saxon compilers reasoned that the humors accumulated over winter, when the body was closed up against the cold and heavy foods sat inside it, needed to be released before the warmth of summer set them fermenting. Several centuries later, in the 1580s, the English surgeon William Clowes, chief surgeon at St. Bartholomew's Hospital in London and one of the most respected practitioners of his day, was still writing that phlebotomy should be avoided in extremes of temperature, and that spring and autumn were the most convenient seasons for the procedure. The continuity of that seasonal reasoning across 700 years and two very different phases of European medicine tells you something about how stable the underlying framework was. From the 10th century to the 16th, the calendar of bloodletting barely moved. Inside a monastery, the practice took on a strangely social character. The monk who had been bled was excused from the choir for several days. He was permitted a richer diet than usual: wine, meat, additional bread. He rested. He recuperated. In some houses, the minutio became a kind of quiet holiday, a scheduled retreat within the retreat of monastic life. Whether the leech played a role in these institutional bleedings, or whether the sharper instruments of the lancet and phleem did, most of the work depended on the specific house and its resources. What is clear is that leeches were kept, cultivated in small ponds and jars near the infirmary, and applied particularly to older monks or to patients whose weakness ruled out a full venesection. A gentle draining, one leech at a time, was considered a merciful alternative for those whose vitality could not spare a larger loss. And it was not only monastic patients who received this treatment. As European towns grew from the 12th century onward, an urban medical marketplace developed alongside the monasteries. In Paris, the barber surgeons had been organized into a formal guild by the 13th century. In Venice, the College of Physicians existed by 1316. In Bologna, the medical faculty of the university trained physicians who would go on to serve princes and cardinals. Beneath these elite figures was a vast layer of practitioners, some formally trained, most not, who tended to the ordinary aches and fevers of ordinary people. Barber surgeons, apothecaries, wise women, wandering empirics, and outright quacks all offered bloodletting as a service. And leeches, cheap, transportable, and applicable by almost anyone with a steady hand, were part of the standard toolkit. A traveler in 14th century Florence could walk into a barber's shop, complain of a persistent headache, and walk out an hour later with 3 small circular wounds behind his ear, still gently oozing. The question of where the leeches came from is one that later generations preferred not to ask, because someone had to gather them. And that someone, across most of European history, was not the physician. It was a class of workers so miserable, so unhealthy, and so poorly paid, that their occupation became a kind of shorthand for the desperate rural underclass. They were called leech collectors, leech gatherers, or leech finders, and their method of work was, on hearing it described, one of the more disturbing occupations of the pre-industrial world. The most productive habitats for Hirudo medicinales were shallow ponds, boggy marshes, and the reed-choked margins of slow rivers. Leeches, being ambush parasites, would attach themselves to whatever warm-blooded creature waded into the water, so the leech gatherers waded in. Sometimes they used old horses or cattle as bait, driving the animal into the water and collecting the leeches from its legs afterward. But more often, because they could not afford to feed a horse, they used their own bodies. They stripped off their outer clothing, rolled their trousers up over their knees, and simply walked into the swamp. Then they waited. When they felt the sharp small pinch of a leech attaching, they let it feed. When it dropped off, gorged, they picked it out of the mud, dropped it into a linen bag or clay pot hung from their belt, and moved on. A French account translated into English and published in the Edinburgh Journal of the Sciences in 1832 preserves an eyewitness description that gives a startling sense of the scene. The passage, quoted in an 1845 English medical magazine and reproduced in the Historical Archive of the Wellcome Collection in London, describes a man walking the borders of a marsh in the region of La Brenne in central France. He is pale, thin, with straight hair pushed under a woolen cap. His arms and legs are bare. He walks in the mud and the standing water. Every few paces he pauses, raises one leg, examines it, then the other. The observer notes that a passing stranger might take him for a fool or a lunatic. He is neither. He is an intelligent leech fisher, and he is at work. The leech is attached to his legs and feet, and he plucks them off one by one and stows them in a small bag over his shoulder. In a favorable season, the passage concludes, an experienced gatherer could collect 10 or 12 dozen leeches in 3 or 4 hours of waiting. The occupation had a cost, Every leech that a gatherer allowed to feed took another 5 to 10 milliliters of blood from him. Over a day, over a week, over a season. This added up to a chronic anemia that dogged the leech collectors for years. A survey of British leech gatherers conducted by the naturalist James Rawlins Johnson in his 1816 treatise on the medicinal leech, published in London, noted that the gatherers frequently complained of dizziness, weakness, and persistent low-grade fevers. Some of these fevers were probably infections, since a leech that had recently fed on a diseased animal could transmit pathogens into the next wound. The Romantic poet William Wordsworth, walking in the English Lake District in the summer of 1802, encountered an old leech gatherer near the town of Ascombe, and the encounter so affected him that he later wrote a poem about it, published as Resolution and Independence. In the poem, the old man, bent and half-deaf, tells the young poet that he wanders from pond to pond, from moor to moor, because leeches have become scarce and hard to find. The lines describe an employment hazardous and wearisome, and the phrasing is not a poetic exaggeration. It is a nearly clinical summary of a profession whose workers were paid in coppers per hundred and paid in their own blood by the day. By the time Wordsworth wrote those lines, the demand that had made leech gathering a viable occupation at all was reaching its historical peak. Because the practice that medieval physicians had used, cautiously and within a framework of astrological restraint, was about to be reborn on an industrial scale in the aftermath of the French Revolution. The physician most responsible for this transformation was François-Joseph Victor Broussais, born in Saint-Malo in 1772 and appointed chief physician at the Val-de-Grâce military hospital in Paris in 1820. Broussais was a veteran military surgeon who had served in Napoleon's armies and returned to civilian practice convinced that the whole edifice of humoral theory needed reform. His replacement was, in a sense, even more radical. In his 1808 treatise Histoire des phlegmaties ou inflammation chronique, Broussais argued that every disease, without exception, could be traced back to inflammation, and that inflammation typically began in the gastrointestinal tract before spreading throughout the body. Cancer was inflammation, fever was inflammation, insanity was inflammation of the brain, and the treatment for inflammation in every case was the same. Local depletion of blood at the affected site, achieved with as many leeches as necessary, combined with a starvation diet that Broussais believed reduced the fuel available for further inflammatory processes. The theory was, from a medical standpoint, spectacularly wrong. But it was also seductively simple, and it fit neatly with the political mood of post-revolutionary France, which distrusted the elaborate academic edifices of the old regime and preferred a medicine that ordinary people could grasp and apply. Broussais became a national celebrity. His clinics at Val-de-Grâce treated soldiers for typhus, dysentery, and enteritis with the same standard prescription, which was the application of 30 leeches at a time to the abdomen, followed by strict caloric restriction. Historians reviewing his hospital records later concluded that his mortality rates were catastrophic. But the survivors, and there were always survivors, credited the leech and the fame of the treatment spread. Between roughly 1825 and 1850, France became the epicenter of what historians of medicine now call the leech mania. Records preserved by the Science History Institute in Philadelphia indicate that in a single year at the height of the craze, France imported 33 million leeches for medical use. The domestic ponds and marshes could not keep up with the demand. Leech farming became a serious industry. Leeches were shipped from Hungary, from Turkey, from the wetlands of the Baltic. British hospitals, unable to source enough from their own countryside, imported from France in turn. American hospitals imported from Germany. Ornate ceramic leech jars, tall-lidded vessels with pierced tops for ventilation, became standard fixtures on apothecary counters and on the mantelpieces of the well-to-do, so that a physician making a house call could apply the treatment on the spot. Broussais died in 1838, but the vogue he had launched outlived him by a full generation. British surgeon Rhys Price, in his 1822 book A Treatise on the Utility of Sanguine Suction, or leech bleeding, praised the therapy for inducing what he called a state of relaxation of the nervous energy of the body, which was Regency-era code for the pleasant lassitude that follows moderate blood loss. Jane Austen, dying of what was probably Addison's disease in Winchester in the summer of 1817, was almost certainly treated with leeches during her final illness. Napoleon's son, the ill-fated Duke of Reichstadt, was leeched extensively before his death from tuberculosis in 1832. The English poet Percy Bysshe Shelley wrote of being covered in leeches during a bout of illness in Italy. The therapy had spread from the medieval monastic infirmary into every drawing room, every gentleman's club, every officer's mess in Europe. And then, quite suddenly, it collapsed. The reasons for the collapse are the subject of a substantial modern scholarship, but the key figure in the reversal is generally identified as the French physician Pierre-Charles Alexandre Louis, working at the Hôpital de la Pitié in Paris in the 1830s. Louis pioneered what he called the numerical method, which was the application of statistical analysis to clinical outcomes. In a study published in 1835, titled Recherche sur les effets de la saignée dans quelques maladies inflammatoires, Louis compared the outcomes of patients with pneumonia who had been extensively bled against those who had not. The results were unambiguous. Bloodletting did not help. In several categories of patient, it appeared to actively worsen outcomes. Louis' methodology, which introduced control groups and quantitative comparison to a field that had operated for 2,000 years on authority and anecdote, was as revolutionary as his conclusions. Within a generation, the tide of medical opinion had turned. By the 1870s, with the germ theory of Louis Pasteur and Joseph Lister providing an entirely new framework for understanding disease, the humoral system that had made bloodletting rational was disintegrating. The leech, which had briefly been the most requested medical commodity in France, became a symbol of everything the new scientific medicine was leaving behind. It should have been the end of the story. Instead, and this is the twist that no medieval physician could have predicted, the leech came back. Not in the form Broussais would have recognized, and not for the reasons the ancient Greeks would have accepted, but for a purpose that turns out to be genuinely and precisely useful in modern medicine. The story of the return begins, quietly, in the reconstructive surgery wards of the 1970s, when microsurgeons attempting to reattach severed fingers and toes discovered that their painstaking work was being defeated by a specific complication called venous congestion. When a small body part is reattached, the surgeon can usually rejoin the arteries that carry blood into it. Arteries are muscular and relatively easy to suture, but the veins, which carry blood back out, are thin-walled, delicate, and often too damaged in the original injury to be repaired at all. The result is that fresh oxygenated blood flows into the reattached finger, but it has nowhere to go. It pools. The tissue swells. Within days, the finger turns purple and dies, not from lack of blood but from the excess of it. Surgeons at hospitals in France, Slovenia, and the United States began experimenting with a strange solution. They applied a live medicinal leech to the reattached digit. The result was almost miraculous. The leech drew off the pooled blood at exactly the right rate. Its saliva, releasing hirudine and vasodilators into the surrounding tissue, kept blood flowing gently through the wound for hours after the leech dropped off, which was enough to keep the finger alive until the body could grow new venous drainage of its own. In 2004, after decades of quiet clinical use, the United States Food and Drug Administration formally approved Hirudo medicinalis as a medical device, making the leech one of the very few living organisms to receive that designation. The approval covered its use in reconstructive and plastic surgery, and specifically for the salvage of skin flaps and reattached body parts threatened by venous congestion. Modern hospitals now purchase their leeches from certified pharmaceutical-grade breeders, most notably a facility called Rika Rimpex in the town of Audenges in the Gironde region of southwestern France, which has been raising medicinal leeches under increasingly strict sanitary controls since 1845. Each surgical leech comes with documentation of its lineage, its feeding history, and its microbial screening. It is used once, on a single patient, and then killed and disposed of in a biohazard container. The medieval physician, watching this from any century of his choice, would have found the sterility strange, but the underlying logic entirely familiar. Excess blood in the wrong place, drawn off gently by an animal designed for exactly this purpose. The leech is not the only medieval treatment that has quietly returned to modern hospitals. In 2015, a team led by Dr. Christina Lee at the University of Nottingham, working with microbiologists at the same institution, published research on a remedy from Bald's leech book that had been sitting in the British Library manuscript for 1,000 years. The remedy in question was an eye salve. The Anglo-Saxon compiler prescribed equal parts garlic and another allium species, mixed with wine and bovine bile, left to stand in a bronze vessel for 9 days and 9 nights, then applied to the affected eye. The Nottingham team followed the recipe with modern precision, using authentic ingredients and reproducing the fermentation conditions as closely as they could reconstruct them. What they found stopped them in the laboratory. The salve killed methicillin-resistant Staphylococcus aureus, the notorious hospital superbug commonly known as MRSA, with an efficacy comparable to modern antibiotics. Individual ingredients did not have this effect, only the aged compound did. Something in the combination, whether a specific reactive compound or a synergistic effect between the antimicrobial agents in garlic and the acidity generated by the fermenting wine, produced a genuine and reproducible antibacterial action. The study, published in the journal MBIO, sent a small shockwave through the medical historical community, not because it vindicated all of medieval medicine, most of which was wrong, but because it demonstrated something more subtle. Some of what medieval healers had learned, over centuries of trial and error, was pointing at real biological phenomena that modern chemistry could now investigate with instruments they never possessed. So how do we now understand what medieval doctors were doing with their leeches? The old dismissive verdict that pre-scientific medicine was uniformly stupid and harmful and only replaced when brave modern men swept away the superstition does not survive contact with the actual documentary record. Medieval physicians operated within a coherent theoretical framework that was internally consistent and produced predictable clinical procedures. They regulated themselves through guilds and universities. They wrote treatises, argued with each other, revised their opinions when new evidence from Arabic or Greek translations reached them, and left behind a documentary trail of thousands of manuscripts that historians are still cataloging. Their framework was built on premises we now know to be false. The humors do not exist. Bloodletting for pneumonia probably killed more patients than it saved. The zodiac exerts no influence on the veins. But within their premises, the practice was rational, careful, and often, in a way that has nothing to do with the underlying theory, genuinely helpful. Bloodletting can reduce blood pressure, which in a patient with a hypertensive crisis is a real intervention. Removing a substantial volume of blood does trigger a mild immunological response that could, in some infections, buy the body a few useful hours. Modern research on therapeutic phlebotomy in conditions like polycythemia and hemochromatosis confirms that removing blood in specific narrow circumstances still has a place in medicine. And the leech, applied with its now understood chemistry to a patient with venous congestion, is doing something that no medieval physician could have described, but that they were, in a small percentage of cases, accidentally accomplishing. The framework has changed. The instrument in some cases has not. In a specialist reconstructive surgery ward at a hospital in Boston or Berlin or Beirut, in the second half of the year 2026, a nurse in a sterile gown lifts a small container from a refrigerated cabinet. Inside the container, in a solution of medical-grade saline, is a leech. She carries it to the bedside of a patient whose thumb was reattached 6 hours ago in a 9-hour microsurgical procedure. The thumb is swelling. It is turning the color of a bruise. The nurse presses the leech gently to the reattached tissue, and within seconds it fastens itself in place, 3 small jaws closing down in a bite so precise it leaves behind a mark shaped like a 3-pointed star. The patient feels almost nothing. The theory around the treatment is entirely different from what a monk of the 12th century would have offered. But the animal, and the shape of the wound, and the slow, steady draw of blood away from a swollen limb are exactly what that monk practiced. Some skills, some tools, some quiet accidental discoveries of what a particular animal happens to be very good at outlive the ideas that first gave rise to them by 1,000 years. The leech is one of those. It began as the tool of a healer whose name meant, in the language of his people, the same word as the creature he handled. And in a small number of operating rooms around the world, that ancient equivalence still, quietly holds. If you want to know what medieval medicine felt like from the inside, this is where to look. not in the caricature of the plague doctor with his beaked mask, not in the cliché of the mad barber and his bucket of leeches, but in the careful, learned, deeply serious physician who consulted his almanac before he made a decision, who trained for years to read the position of the moon against the vein of a patient's arm, who applied a small living creature to a chosen spot on the body because he genuinely believed, with the best evidence available to him, that he was easing the balance of a suffering human being. He was almost always wrong about why the treatment worked when it did. He was often wrong about whether it worked at all. But he was not stupid, and he was not a fraud. He was a professional working inside the best theoretical framework his civilization had produced, using tools that a very small number of modern surgeons still keep in the refrigerator down the hall. And the next time you see a diagram of the Zodiac Man, or a leech jar in a museum case, or a photograph of a small three-pointed wound on a reattached finger, remember that the distance between his world and ours is not quite as vast as it looks. The leech survived. So did some of his remedies. And so, in strange corners of modern medicine, did the deeper intuition that gave rise to both. That a body out of balance sometimes needs, above all else, to be quietly and carefully drained.